Morning, y'all. I'm Anthony. I'm come up from Birmingham, Alabama. I'm a pharmacist with Pharmacy Link Inc. Dr. Shah wanted us to come by today. We're part of the Atlantis Health Network. We are a specialty in compounding pharmacy, and we're going to talk a little bit about topical pain therapies as an alternative to oral therapies, and then how y'all can actually implement that here and utilize that for your patients. Pretty easy process. But just a little bit of background on me. I'm licensed personally in 15 states. Our pharmacy is in 47. We're probably not going into California, but we're on our way to 49. We are a specialty pharmacy. We are accredited nationally for compounding. And what that lets us do basically is just get prescriptions to people that are a little bit more customized if something's not commercially available. And the specialty aspect just means that, some products that are manufactured that are specialized, not necessarily available in the normal retail channels and things like that, direct relationships with manufacturers, a little more consultation driven, say like an injectable or something that a patient needs a little bit more assistance using. We're focused on pharmaceutical care, which is just delivering drug outcomes instead of just prescription fulfillment, actually focusing on the outcomes and patient utilization, things like that. We do have specific formulas we've developed in conjunction with providers for things like pain, dermatology, and wound. And we also do wellness focus, metabolic support, those sorts of things. But today we're here to talk about pain specifically. So right now, basically we're in the middle of, people call it opiate crisis, heroin epidemic. You're seeing all these words getting thrown around. And I think this week they're calling in Congress, I think Congress is in session Tuesday to Thursday or Tuesday to Friday or something like that, but they're calling it Opiate Week. There's at least 6 or 7 bills in between the House and the Senate getting passed back and forth. One of them is on its way to reconciliation potentially, so it's been kind of given the green light by both chambers. Last night, I didn't catch it, but one of my staff said Sanjay Gupta had some big thing on opiate crisis and epidemic, like a town hall kind of deal. Since 1999, the number of opiate prescriptions in the U.S. has quadrupled. Over 165,000 people have been killed. And we're talking about specifically from prescription drugs. We're not talking about heroin, that kind of third bullet point downstream effects like violence or something like that. This is strictly just prescription usage as directed by a provider, filled out a pharmacy, 165,000 deaths. You'll see that number a lot higher. I went with one that I could have well verified in the literature. How y'all doing? Folks just walked in. We're talking a little bit about topical pain today. I'm a pharmacist with Pharmacy Link Inc. My name's Anthony. But last year, I think you could see as high as like 50,000 people or something like that. So if you go back and do the math from 99 to today, if that number is more on the right end, this could be significantly bigger. The reason there's not a good grip on this and you see different studies or literature reports is because the reporting requirements and how things are done state to state vary so much. For comparison, Vietnam War death toll, 40,934. That's from the U.S. government archives. In one study, when they looked at illicit opiate users, heroin, street-acquired narcotics, whether long-acting or short-acting, opium in its raw form, it's not necessarily heroin, things that are being imported these days. About 75%, and again, you'll see that number higher. That's just a well-verified number. You'll see that closer to 90% in some studies. About 75% of those people will report they started using prescription medication to develop that habit. This is not people that had a leg amputation or some sort of chronic musculoskeletal injury. These are people that had short-acting opiates for a week or two at a time in a lot of cases. That was their first run-in with opiate effects. The limitations and downsides are clear, but what are the options? I'm not just here today to talk about the problem. This is cliche at this point to a lot of providers. I know they've heard this drilled into them from both industry, like your Academy of Pain and everything. We're also going to talk about some solutions. Yes, sir.
I have a question.
Yeah.
The people who died from overdoses, they were prescribed these drugs.
Yes, sir.
And were they being monitored by a physician?
As far as this number in this study, I don't know if they included that in there, but generally, it was part of either a short-acting treatment protocol where they were going to get some kind of follow-up, like an orthopedic situation, or pain patients. This includes everything, though, oncological patients, stuff like that. So as far as their follow-up, I'd have to drill down a little bit more, but presumably they were under medical care. It wasn't just, here's a prescription and,
Yeah.
They were under someone's treatment protocol at that point, presumably.
Interesting. Yeah, because I mean, to say has been killed, that's a very provocative term. They died. They were being killed is an intentional thing.
True, that might be phrased a little strong.
I mean, it is. It's.
What would you suggest there have been?
Suggest incompetence at least on the part of a physician, or else the person themselves is taking an overdose.
Like intent for.
Of some intent.
What do you think would be a better word that wouldn't imply intent?
Well,
maybe
I'd say they died
casual,
because that's a past
had died, a little less
But,
judgment. I appreciate that
but
feedback.
it's a big. I mean, that's a huge number, regardless of
Yeah.
the terminology.
Agree. That's a good point. And anytime y'all want to chime in, please appreciate that input, sir. And oral opiates, NSAIDs, and pain generally, kind of where things stand. All the guidelines, as a standard of care, reference using opiates and NSAIDs. It's just whether it's the American Pain Society, American Academy of Pain Management, chronic opioid therapy can be effective therapy for carefully selected and monitored patients with chronic non-cancer pain. However, opioids are also associated with potentially serious harms, including opioid-related adverse effects and outcomes related to abuse potential. So this is kind of one of those hedge terms. It's like it's an accepted standard of care, but there's risk and there's harm. NSAIDs, of course, just pulling some of the ones that came up in the guidelines. There's cox-selective and non-cox-selective like ibuprofen, widely recommended for acute and chronic pain conditions. As far as safety risks, every drug, every pharmacological therapy is going to have its therapeutic outcomes. It's going to have some adverse drug events that are possible as well. Everything from Tylenol up to the most sophisticated chemotherapy. With opiates, everyone's probably familiar. How you doing, sir? Addiction, respiratory depression, sedation, constipation. These things can be expensive. Some of the longer-acting opiates are brand name, and not here to discuss drug pricing or anything, but they can be many hundreds of dollars a month for private and federal payers. And oftentimes you're doing a quality of life trade-off between ADRs and pain relief when you're thinking about opiate therapy and pain management. For NSAIDs, on that bottom point, viewed as benign by a lot of patients, at least from my experience as a pharmacist. I don't know if that's because they're used to having them be readily available over the counter, or if they're just so ubiquitous or what have you. But they are associated with a lot of morbidity, especially when used chronically, GI irritation, possibly from short-term use, GI ulceration, and bleeding if you have some pre-existing factors of more chronic use. They do have antiplatelet effects, cardiac risk increase. It's what's called a black box warning. You're probably familiar with just the FDA officially saying the labeling has to include warnings about these risks. Stroke, hypertension associations, that's because they do increase sodium and fluid retention, which can lead to have effects in everything from heart failure just to stroke and hypertension. Acute and chronic renal dysfunction, NSAIDs can affect the function of the kidneys both acutely and long-term through how they stop certain prostaglandin effects, and drug interactions, of course. It's kind of outside the scope of the conversation. There's thousands of potential drug interactions with both opiates and NSAIDs. And the only reason I'm painting this picture is not to say any one treatment is not appropriate, but we're just kind of laying out some of the costs and benefits and everything. And of course, the whole self-medicating by patients. Sometimes they'll be on a very detailed, very well-monitored treatment protocol from a clinic, and to be self-medicating as well with NSAIDs is something we see a lot. When we ask a patient, hey, what's your med list? They're like, okay, well, it's these 10 things. Well, what else do you take? You get a whole other list of, ibuprofen, vitamins, these sorts of things that are viewed as completely benign that, as we know, have serious pharmacological effects. Right now, we kind of talked a little bit about what the media is calling opiate crisis, heroin epidemic, these sorts of things. It's not just the media. A lot of our three-letter Washington, D.C. organizations, FDA, DEA, CDC, are both speaking out and acting as well with their enforcement and administrative power. Again, the guidelines do recommend usage of the opiates and NSAIDs. On the one hand, we're seeing, recommendations to providers to use these things, and then federal agencies and industry bodies coming and issuing warnings. So where's kind of the balance between that is where this is going. 2013, the FDA issued a warning over long-acting opiates. They required some labeling changes. That's one of the things the FDA can enforce is what labeling needs to go on a product. And hey, welcome. Just to kind of lay out the risk a little bit more and some safety warnings. 2014, I'm sure this affected some of your practices. The hydrocodone was rescheduled to Schedule 2. Patients that had a 6-month Norco prescription are now coming every month. I don't know how y'all implemented that or if y'all did something different, but that's a big difference. It's everything to the patient. I mean, some of these people already have a quality of life burden. Now they're doing extra visits to the clinic. It's a big logistical thing. The DEA did that because more or less trying to restrict access might be kind of a strong word, but just kind of control the monitoring that was going on through just a broad administrative technique. 2016, the FDA issued a warning for immediate-acting opiates. These are our hydrocodone, acetaminophen products, oxycodone, acetaminophen products. And then the American Academy of Pain Medicine in 2016, this year, recommended a REMS program for long-acting and short-acting. A REMS program, it stands for Risk Evaluation and Mitigation Strategy, which is basically, has anybody either known or taken like Cloravis, like isotretinoin, or like a friend or loved one, or like drugs like clozapine? There's a really popular acne medication called Cloravis, also known as Accutane. And to take something like that, you need to go to the doctor, get a pregnancy test if you're a female, bring that to the pharmacy. Before the prescription can be dispensed, there's a real-time database where you're plugging in those results. It's this really carefully controlled program for risk and everything. So this is a medical body coming out and saying we need to implement something like that for opiates. So, you can imagine on top of the Schedule 2 now the patient's got to come in and get blood work, which you're probably already doing urine drug screens and things like that, and then tying that information to the dispensing point at the pharmacy, and increase patient communications, handouts, these sorts of things. So that's, another potential layer coming down the pipe. 2016, this was just a few weeks ago, the CDC put out some new guidelines and a warning kind of document. I'm sure y'all might have seen this. But in there, one of the first points, I think that's point number 6, or recommendation number 6, they basically say, when you're prescribing opiates, most cases you're only going to need equal to or less than 3 days, and in some cases maybe equal to or less than 7 days. It's part of a series of about a dozen other recommendations. That's not a standalone, here's how you use opiates, but that was in there, and that's getting a lot of talk. And the director, Thomas Frieden, made a statement, we know of no other medication routinely used for non-fatal conditions that kills patients so frequently. So that's, again, he went with the kill context, but it's a significant statement from a national organization's director. There are some alternatives to this. In the guidelines, they reference using non-pharmacological therapy with opiates, right, like physical therapy, other interventions y'all can do, as well as non-opiate pharmacological therapy, and that's kind of what I'm here to point out a couple today that might be useful for these providers. Non-opiate pharmacological therapy can be good, like NSAIDs that are taken orally, but we already kind of reviewed those side effects. Topical therapies have the advantage of getting medication at the active site where it's needed and not filling up those parts of the body with either therapeutic or toxic doses where the medication is not needed. So when you use a medication topically, and I always use the example of a knee because Voltaren 1% gel, diclofenac 1% gel is approved for use on the knee by the FDA. You're getting a less net dose. So if you take a gram of 1%, you got 10 milligrams in there versus an oral tablet where you might be getting 50 milligrams of diclofenac and all these different body tissues. So you're getting a less net dose. Also potentially decreasing the dose of other therapies. We'll talk about topical diclofenac and topical lidocaine use here in a moment. If someone's on, short-acting opiate, they're on gabapentin, they're on a muscle relaxer because they have an injury to a lower extremity, say, if they're taking an anti-inflammatory and a numbing agent, if we can bring down that gabapentin dose and the oral NSAID and the muscle relaxer dose, we can affect a lot of different therapies, max doses. The lower the dose, usually less is more in pharmacology. We're just getting those therapeutic outcomes, not getting those side effects, hopefully. With topical therapy, we can avoid systemic doses, period. If we're trying to get diclofenac molecules to the knee, why are we getting them in the central nervous system, kidney, cardiac system, you name it, hepatic system? No oral pill burden. A lot of patients, that's a big thing. This is a very patient-friendly dosage form. We use the term elegant sometimes in topical therapy and in compounded formulations. It's something that's, it's patient-friendly. It's not tacky. It's smooth. It's a vanishing preparation, that sort of thing. And the patients, they feel in control of it. It's something that they can reach for instead of that bottle of NSAIDs or opiates or something like that. A lot of folks, this is really popular in is athletes, elderly, young, people with really specific problem like concomitant like bleeding conditions and things like that. A patient already on blood thinners, you don't want to add oral NSAIDs to. This is a good solution to maybe get them some medication. Some examples of what we're talking about. There's a diclofenac one. These are FDA approved, commercially available, meaning you could go to Rite Aid or an independent pharmacy, hopefully, and get something like this. Diclofenac 1.5% solution, 1% gel. There's a lidocaine 5% ointment, patch, and a bunch of other strengths. These things have been studied. They're FDA approved. They've been on the market long enough to be generic to now. Proven absorption, safety, and other effects. There's compounded topicals available as well, where as a provider you say, well, I just want clonidine and ketoprofen in this formula. That could be made up by a pharmacist specifically for an individual patient. Again, using bases and ingredients that have proven absorption and effects and things. So a lot of what we're going to be talking about is, for examples for topical therapy, is going to be diclofenac solution and lidocaine ointments and things like this. As far as the efficacy goes, the diclofenac 1.5% solution, the American College of Rheumatology recommends topical NSAIDs right at the same tier as oral NSAIDs, as well as tramadol and acetaminophen. And that's really significant. I mean, it's a recognition of how effective these things can be. If we can have a topical NSAID do the job an oral one can, there's no reason to use an oral NSAID. I mean, GI distress, stroke, hypertension, renal dysfunction, drug interactions, even just oral pill burden and cost. The guidelines elsewhere don't necessarily give as strong of a recommendation for topical NSAIDs versus oral. You'll see it mentioned sometimes, well, these need more study. Okay, they were FDA approved 15 years ago. There's been millions and millions of people on there. I'm not sure what the threshold of studies is and evidence they're looking for, but at least this college has recognized the efficacy of topicals. Improved safety profile for the topical diclofenac is one of the big advantages, even though this is a slide about efficacy. There's essentially just this one underlying kind of common sense argument that we're getting drug levels in local tissues, not systemically, to achieve the effects, and that's keeping us away from side effects. Diclofenac's COX selective. There's two COX enzymes. There's a lot of COX enzymes, but COX-1 and COX-2 that are discussed. COX-2 gets made in inflamed tissues. We're trying to beat that activity down to stop inflammation. COX-1 is the good COX enzyme. That's the one that's protecting our stomach and renal function and all that. NSAIDs like Celebrex and diclofenac select for the COX enzyme. That's COX-2. That's usually associated with inflammation. That way you keep the COX enzyme that are protecting the body. The diclofenac's, elegant dosage form, I used that word previously, the patients are in control of. That just kind of means that it's not an uncomfortable user experience. It's a solution that's smooth, it's going rubbed into the skin. They do need to wash their hands after, and we always label things with warnings like don't touch the eyes or food, stuff like that. Extensive usage and safety history, generics available. Generics available just meaning the brand name has been out there. They've been doing that post-market surveillance. It's still established therapy, and it's being generic. Like it's been around long enough to expire its patent, as opposed to something like Vioxx, which was pulled from the market as a brand name drug. As far as lidocaine, what we see a lot of times is providers using diclofenac and lidocaine together. A lot of times it's because there's a neuropathic component to the pain. In another case, it could just be because the lidocaine provides immediate numbing effects and can build some steady state levels in deeper tissue with repeated use. It is FDA approved for topical anesthesia, including post-herpetic neuralgia. The lidocaine 5% patch, Lidoderm patches, that one got to market being studied for post-herpetic neuralgia. You're seeing a lot more utilization off-label. As y'all probably know, Lidoderm patches and lidocaine ointments are being used for a lot more than just post-herpetic neuralgia. Like many drugs, the FDA says you can use it for this, and in reality, providers get to make the choice for that individual patient. Lidocaine has been studied and has established efficacy, and in the references, you can see where I'm getting some of these different conditions and indications, but painful idiopathic sensory polyneuropathies, complex regional pain syndrome, carpal tunnel sequelae, post-surgical and post-traumatic pain have all had the lidocaine ointments and things studied where we're basically doing a topical application to stop some of that nerve firing, getting back to the brain, signaling pain. Similar efficacy compared to pregabalin, which is Lyrica, and gabapentin, with a minimal risk of systemic adverse events and drug-drug interactions. There's a lot of important statements there. Lyrica, and I'm not here to disparage or promote any brand name drug. I've no conflicts, don't work for any of these manufacturers, but Lyrica is a Schedule 5, so that's kind of an important issue if you have a patient on multiple controlled substances already. It's associated, as well as Neurontin, with weight gain, sedation. It's Scheduled 5 by the DEA because it does have some abuse potential, and people that are already predisposed to abusing things like alcohol and other pharmacological agents. Gabapentin, huge pills, massive doses, sedation, weight gain. These sorts of things, people report feeling funny, somnolence, distraction, decreased concentration. Because what we're doing is we're getting these agents that are nerve deadening agents essentially all over the body, the CNS specifically, when we're trying to stop a peripheral neuropathy. And just basic anatomy and physiology, I mean, we can get at those neuropathies with topical lidocaine as well. It's not appropriate for every situation, and it's not that there aren't contraindications or people that can't use lidocaine, or not that there's no side effects, but it's just one of these things where it's certainly probably not being utilized as much as it could, considering the drug-drug interactions aren't there, and the risk of adverse events are lower or minimal if you're using it in limited peripheral doses. As far as compounded topical medications, compounds aren't FDA approved. Compound is something a doctor can recognize a patient needs and have a pharmacist make specifically for that patient. The example on the bottom, this is a very popular formula we do nationally. Ketamine, an anesthetic, baclofen, smooth muscle relaxation, gabapentin, diclofenac, and bupivacaine. Gabapentin being, of course, topical in this case, avoiding some of their side effects. Diclofenac, 3%, stronger than the 1% FDA-approved strength, and bupivacaine, a numbing agent. Again, hasn't been studied by the FDA. With that said, there's millions of people who take these things every day. There are some studies that have been done in the literature where you can see people going head-to-head with oral pain medicine with FDA-approved topicals like diclofenac 1% and better safety reporting in those cohorts and better efficacy outcomes as well. Now, with that said, I'm not here to make claims about compounds, reducing by X% versus commercial. It's not something the FDA lets us do, but there are studies available that show that. Safety of topicals in general, just to kind of beat this in one more time, I mean, what's underpinning all this is there's less systemic absorption of the medication when you're using a topical than when you're taking it orally or injection, intramuscular administration, etc. Less dose means less adverse drug reactions, ADRs, for several reasons. There's less drug there. It's going to have less of an effect if, you have the therapeutic levels are here, and when you blow through that, you get into toxic levels. We're not getting even up to systemic therapeutic levels. It's just therapeutic levels where we need it. The body, when you take a drug, it's got called a volume of distribution. You might have heard that term. The volume of distribution in the average male or female is very large. So you're taking a diclofenac tablet or something to get a few milligrams or micrograms to a peripheral compartment like the knee. If you can achieve that topically, then I'm just here to kind of make the argument that's probably a little bit more logical approach. Overdose situations, we have had patients call in and see in the literature where someone says, hey, I used a whole bottle or something like that. I swore I wouldn't do math in public, but I'm going to give you an example. There's 150 ml bottle of diclofenac 1.5%. We had a lady use almost the entire bottle, and we had to go back and calculate, okay, 100 mLs, which is literally a month's worth of medication rubbed on our arm essentially. Calculating that down, so it's 1.5%, 100 mLs. You can really see that it's less than at 3% systemic absorption, it was about 45 milligrams that she might have gotten systemically versus a 50 milligram diclofenac tablet. So there's built-in safety thresholds there. When you're putting on topical diclofenac, a lot of the studies show a 3 to 6% absorption max. There are absorption enhancers in these products like DMSO that help drive them in. If we can get to deep tissues like a knee or something, there is going to be some winding up in the bloodstream, but I operate under the 3 to 6% number for most products. That does change with things like steroids. They have, full absorption. But during these overdose situations, the comparable systemic side effects are low because they really just kind of approach those therapeutic dose systemic levels they're getting anyway when they're using the oral tablets. There's no abuse potential with this stuff. It has no street value. Accidental or purposeful misuse kind of has some built-in safety. The most common reaction, we serve thousands of patients a month nationally, is rash. Of course, if there are already reactions, we have a responsibility to report that to the FDA's MedWatch program. But most commonly, what you see is a few percent of people in our practice calling back and saying, hey, I have a little rash. And at that point, of course, we stop therapy, call the doctor, recommend an alternative. Don't leave the patient hanging. As far as place and treatment protocol, in the guidelines, these are oftentimes, with the exception of the Rheumatology College, in the CDC guidelines and American Pain Society, these don't get a huge rating up there with oral NSAIDs, Tylenol, those sorts of things. I would argue as a pharmacist that if you're looking for someone to have multimodal therapy, like they're on NSAIDs and opiates, these sorts of things, it could be first line. If an oral NSAID is going to be up there at first line, and we know that we can do topical the same absorption, why not try topical? at least have it accessible to the patient. If there's patients in certain situations, like their high bleeding risk, high risk of abuse potential, already taking oral meds, that could be a good indication that it's time to try a topical. We have a few pain clinics that everyone on an oral NSAID and opiate are on the oral diclofenac and lidocaine. We're having a lot of success with that, decreasing max doses. It's something that patients can reach for when they're self-medicating with those OTCs and things like that. Lidocaine, some of the recommendations from the studies are after first-line agents like Lyrica and gabapentin, and yet some of those same studies will show that you can have the same efficacy. So I kind of look at that argument as like, well, why are we waiting to try something that potentially has side effects and then try something that has the same efficacy? If there is someone who has peripheral neuropathies or something like that, it might be a good idea to start with diclofenac and lidocaine, either with those oral agents, that again, one of which is a controlled substance, the pregabalin, and of course, utilize whenever it is seen as appropriate by y'all as providers. You don't necessarily, the guidelines aren't law necessarily. Topical ointments, creams, and gels are readily available. What we mean by that is, it's great to talk about different therapies that are available, but as y'all know, if insurance doesn't cover them, and if you can't get them to patients, it doesn't really matter. It's just going to be a phone call to the office or a prior authorization that's not going to go through. These things are generic medications. They're FDA approved in a lot of cases. They're generic copays. There's not prior authorizations involved and stuff like that. So that's important as far as patient access goes. But as far as treatment protocol, what I would recommend is looking for this is if you have people on oral NSAIDs and people on opiates or any sort of neuropathy medication, gabapentin, pregabalin, maybe trying a topical lidocaine and diclofenac as well or in place of, depending on your comfort level. As far as how do you utilize these things, you can hand the patient a prescription. We've got some prescription forms from the Atlantis Health Group with us today with pharmacy fax number and stuff on them. If you follow the normal prescription, I find this is kind of alarming to prescribers a lot of time. 50 to 70% of these prescriptions, that's all that's making it to the pharmacy. So half of them just go ahead and throw in the trash. You know which ones are going to make it. Potentially any narcotics, those are going to make it. That's why in the emergency room, must fill all the antibiotics, those sorts of things. But in an ambulatory practice, this turns into a huge problem when you're trying to get the patient's therapy. You're trying to get feedback on them from the therapy you're presuming they're on. You look at these numbers and it can look like an impossible situation sometimes. 50% of the prescriptions may not make it to the pharmacy. Only 48 to 66% may be picked up from the pharmacy. Well, there's a lot of reasons. I don't want to pay that copay. I've got a deductible. I'm not paying that right now. Very understandable price point issues with patients. Other reasons could just be lack of compliance, which is like forgetfulness or I don't want to do that. 25 to 30% are taken properly, meaning take this drug 3 times daily with food. Y'all know the story here as providers. It's some drugs aren't being refilled, but every 3 months when it's a 1-month supply, those sorts of things. 15 to 20% are refilled as prescribed, which really, kind of eats up that previous stat. If they're not being refilled as prescribed, they're probably not being taken as prescribed. And the cost of this stat is from the National Chain Drugs Lobby, but they say it's about $290 billion annually. And what they're saying there is, okay, well, you didn't get the medication. CHF is always the big example. Somebody didn't pick up their Lasix after discharge, now they're back in the hospital, that sort of thing. But there's implications elsewhere for pain. They're not using their prescribed therapy, whether it's a long-acting opiate or a neuropathy agent or this diclofenac and lidocaine. They're not using that, so they're reaching for OTCs. They're doing things with high ADRs, then they have a hospital admission or something like that. So the cost can spiral out of control pretty quickly. For pain, when we have this kind of lack of compliance or lack of fulfillment, whatever you want to do, they're not getting their pharmacological therapy. For pain, it creates an over-reliance on things the patients relate with immediate response. Over-the-counter NSAIDs, the opiates, things like that, where they could have been relying more on anti-neuropathy medication. Thanks, y'all. Thanks for letting me come up here.